Hello everyone, I am Dr. Madhavi, working as a professor in the Department of Obstetrics and Gynecology, SC Medical College, Tirupati. My postgraduates, Dr. Maulya and Dr. Lata. We are going to present a case discussion on hypertensive disorders in pregnancy. Okay, let us start the discussion. Maulya, present the case.
Good afternoon, myself Maulya. I am going to present a case on hypertensive disorders in pregnancy. This is a wife of Mr. Y, who is 30 years, aged about 30 years, resident of Pandarpalli, Airport, Mandal, studied till 10th class, who is a homemaker by occupation, belonging to lower middle class socio-economic status. She is a fourth traveler with para-2 leading to abortion with 9 months of gestation, who is referred from private hospital Karasti in view of high BP recordings of about 160 by 100, attended the OPD with
complaints of swelling of both feet since 1 week, complaints of dizziness since 1 day.
Her cycles are regular and her LNP was 14th August 2025 and the expected date of delivery was 21 May 2025. Her date of admission into this institute was 18th April 2026 and date of examination was 19th April 2026. At the time of examination, her gestation age was 35 weeks 3 days gestation age. A history of present illness, she was apparently normal 2 days back, after which she developed dizziness, attended to the private hospital at Karasti. She was diagnosed with IBP recordings and then referred to Government Medical Hospital, Tirupati. There are no complaints of headache, no complaints of blurring vision, vomitings, epigastric pain, no complaints of reduced urinary output, no complaints of pain abdomen, no complaints of reduced perception of fetal movements, no complaints of bleeding per vagina, no complaints of leaking per vagina. History of present pregnancy, first trimester, she conceived spontaneously, confirmed pregnancy by UPT at 2 months of familiarity. No history of vomiting.
When she was diagnosed as hypertension, no?
Just 2 days back she diagnosed with private
Started
hospital.
any treatment?
Yes, ma'am, she diagnosed with hypertension and started level 12 UPT and referred to our hospital in At first trimester, there is no history of fever with rash, no history of pain abdomen, no history of vaginal bleeding, no history of leaking per vagina, no history of any drug intake or radiation exposure. Dating scan done at 3 months of gestation and it's corresponding to her gestation age. Folic acid supplementation taken.
What is the importance of dating scan?
If her LMP is not sure and her cycles are not regular, she conceived in lactation and malaria and then we confirmed the period of gestation according to every week scan.
Why it is so called dating scan?
If she was not sure of her dates, then we expected date of delivery.
See, it's not like that if she doesn't know the dates. So dating scan means
disparity.
Yeah. What is the period of disparity?
If there is in first trimester, if this period of disparity is 1 week, then we can go with the scan.
Yeah, actually the disparity in the first trimester is approximately plus or minus 5 days.
Yes.
So that is why it is so called dating scans. Okay, so we'll definitely advise the patients to take the dating scan in the first trimester. Okay.
Folic acid supplementation taken from 2 months of familiarity. In second trimester, total number of antenatal visits was about 2 visits. 15 felt at the 5th month of familiarity and she continued to pursue fetal movements too. Anomaly scan done at 5th month of familiarity and it's said to be normal. First and second dose of tetanus diphtheria vaccination taken. No complaints of pain abdomen, headache, blurring of vision, epigastric pain and no complaints of vomiting. Taken an iron folic acid supplementation and calcium supplementation from 4th month of familiarity. No history of polyuria, polydipsia and increased appetite. No history of bleeding per vagina, no history of leaking per vagina. Coming to third trimester, total number of antenatal visits were 3. Patient had history of swelling of both feet since 1 week. No history of headache, no history of decreased urine output, no history of epigastric pain, no history of bleeding per vagina, no history of leaking per vagina. Growth scan was done at 8 months of familiarity and it's said to be normal and it's corresponding to the period of gestation age. And her menstrual history, she attained menarche at the age of 14 years. Her cycles are regular. She bleeds for about 4 to 5 days for every 30 days. Changes 3 pads per day, not associated with any clots, not associated with dysmenorrhea. Her cycles are regular. Marital history, she is married at the age of 25 years. Her marital life was 5 years. It's a non-consanguineous marriage. No history of any contraceptive usage. Obstetric history, she is a 4th traveler with para-2 leading to abortion. First pregnancy, which was about 4.5 years back, which is an induced abortion at 5 months of familiarity in view of uncontrolled BP recordings and it was verified. And second pregnancy, it's a full-term pregnancy, normal vaginal delivery, male child of about 4 years, delivered at private hospital, baby is active and healthy, immunized till date. And next, coming to third pregnancy, it's a full-term delivery, normal vaginal delivery, female child of age about 2 years. It's at private hospital, Srikalahasti. Baby is active and healthy, immunized till date, and fourth pregnancy is current pregnancy. And past
What is the percentage of recurrence of hypertension in the next pregnancies?
25 to 30% of pregnancies land in hypertension if she had a previous history of hypertension in previous pregnancies.
Okay.
Next, coming to past history, BP recordings present in first pregnancy. She is not a known case of diabetes, asthma, epilepsy, thyroid disorder, tuberculosis, cardiac disease. No history of any previous surgeries, no history of blood transfusion, or no history of iron sucrose infusion. Family history of hypertension present in family. Her mother is a known case of hypertension since 30 years. She is on medication. No history of diabetes mellitus, no history of any congenital anomalies, or no history of twins in the family. Personal history.
What is the percentage of hypertension if the mother had a previous history of hypertension
20,
to the daughter?
20%.
Suppose if the sister is had history of hypertension.
3 to 40% risk of having.
40%. In the case of twins,
In case of monozygotic twins, the risk increases to 60%.
it's 30 to 40%, I think so, not 60. It is not 60%, it is only up to 22 to 47%. That too in the monozygotic twins. Okay?
Next, personal history. Consumes mixed diet. Her sleep and appetite are normal. Bowel and bladder habits are regular. No history of substance abuse. No history of smoking or alcohol consumption. No history of drug allergies. And coming to general examination, my colleague Lata will continue with this general examination.
General examination. Patient is conscious, coherent, cooperative, and she is oriented to time, place, and person. The patient is well built and moderately nourished. On examination, mild pain are present. There is no icterus, no cyanosis, no clubbing, no lymphadenopathy. There is bilateral grade 2 pedal edema present.
How do you demonstrate pedal edema?
We have to ask the patient to lie down in a supine position, and we have to expose the legs. We have to press the shin of the patient for about 30 seconds.
Shin of the tibia.
Shin of the tibia for about 30 seconds, and accordingly we have to grade the edema.
Okay, how do you differentiate physiological from pathological edema?
Physiological edema, it may occur mostly in the third trimester. It usually occurs in the dependent parts. It usually subsides after 12 hours of rest, and it is not associated with high BP recordings. Whereas in case of pathological edema, it may occur in any gestational period. It usually occurs in the non-dependent areas, for example, face, hands, abdomen, bundle region. It won't subside after 12 hours of rest, and it is associated with various conditions, for example, cardiac diseases, renal factor, renal diseases, liver diseases, or other conditions like infections, for example, filariasis, DVT, and so on.
Now, how do you differentiate a filariasis from your hypertension?
In filariasis, there will be unilateral edema. There will be associated, there will be pain in.
It is a pitting edema in filariasis?
No, madam, it is a non-pitting type of
That is a
edema.
differentiating.
Whereas in case of hypertension, it is a pitting edema, which is usually bilateral, madam.
Now, what are the grades of edema?
So usually there are 4 grades of pedal edema, ma'am. First one, it is to ankle. The second grade, it will be just below knee. In third grade, it will be above knee. Whereas in fourth case, it is underside, which is generalized edema.
Okay, what is the etiopathogenesis of edema?
In case of this hypertension, there will be endothelial damage, which leads to the externalization of the fluid into the third space, which causes edema, and also there will be an increase in the hydrostatic pressure and decrease in the oncotic pressure because of the loss of the proteins, so which leads to edema.
Okay, continue.
So on neck examination, there is no swellings. On breast examination is normal. Spine and gait is normal. So next comes weight. The pre-pregnancy weight is 40 kg. In pregnancy, she gained a weight of almost 11 kg. Her pregnancy weight is 51.
What is the normal weight gain during the pregnancy?
Normal weight in pregnancy is around 8 to 11 kg.
According to trimester wise?
In first trimester, overall weight gain is up to 1 kg. In second trimester, up to 5 kg. In third trimester, up to 5 kg.
Okay, how the BMI is related to the preeclampsia?
If the BMI is greater than 35 kg per meter square, then there is a 40% risk of developing a preeclampsia.
Okay, continue with the case.
Height is 147 cm. The BMI is 18.5 kg per meter square. Vitals of the patient at the time of examination. Temperature is 98.6 Fahrenheit. Pulse rate 92 per minute. which is regular in rhythm, normal in value, normal in character, no radial or radiofemoral delay. Blood pressure is 140/90 millimeters mercury, measured in the sitting position in right upper arm. So respiratory rate is 16 per minute and saturation is 98% under lumen. Coming to systemic examination, on cardiovascular system examination, S1, S2 present and there is no normal. RS examination, normal vesicular bed sounds heard and there is no added sounds. On CNS examination, no focal neurological deficit. Coming to abdominal examination, on inspection, shape of the abdomen longitudinal oval, umbilicus central and inverted, linea nigra and stria graviorum are present, no sinuses or dilated veins or scars present, hernial orifices appears to be normal. On palpation, fundal height corresponds to 34 weeks of gestation. On fundal grip, soft, broad, irregular, non-bilateral mass found, suggestive of breech. On lateral or umbilical grip, irregular knob-like structures present on the right side, which is suggestive of the fetal limbs, and irregular continuous curvilinear resistance felt on the left side, which is suggestive of the fetal spine. On first pelvic grip, hard, globular, bilateral mass is present, which is suggestive of the fetal head. On second pelvic grip, both hands converging, suggesting fetal head is not engaged. So Liker also appears to be clinically adequate.
So in which group you want to tell about the Liker?
In which group? Lateral.
Yeah, you have to tell in that now. Usually the lateral grip gives about the what is the lie and where is the back, where is the spine. And also you should tell about the Liker in that grip only, not in this. Okay. So what's the provisional diagnosis?
The provisional diagnosis is 30 years old, gravid of 4, para 2, live to abortion 1, 35 weeks, 3 days gestation age with severe preeclampsia with single live fetus in longitudinal line in cephalic presentation with good cardiac activity and not in labor.
Tell me about the management of the case.
First of all, we admit the patient and we will go with the routine blood investigations such as complete blood picture, LFT, RFT, serum coagulation profile, serum viral markers, serum electrolytes, and then
What is the importance of RFT?
Preeclampsia is a multi-system disorder. If the renal involvement is present, then there is increased blood urea. Blood urea will be more than 14 grams per deciliter, and the uric acid will be elevated. It is more than 4.3 milligram per deciliter, and the serum creatinine is also elevated, more than 1.1 millimoles per deciliter.
What about LFTs?
If a hepatic involvement is present in case of preeclampsia, then liver enzymes are elevated. In that too, if the patient is landed in HELP syndrome, LDH will be markedly elevated. It will be more than 600 millimoles per deciliter.
Okay. Then what about the urine examination?
We'll do complete urine examination and the urine protein. In that we will go for whether any proteinuria is present or not. Already if the patient is having any renal disorder cause for hypertension, then there will be renal CAS. You can rule out glomerulonephritis and nephrotic syndrome from other causes of hypertension can be ruled out by doing the urine protein.
What is proteinuria, Maulya, and how do you grade the proteinuria?
If urinary protein in 24 hours is more than 300 mg or 30 mg per deciliter of proteinuria, then it is known as significant proteinuria. There will be 5 grades of proteinuria in dipstick. If it's a trace means about 10 mg per deciliter. In +1 there will be 30 mg per deciliter. In +2 there will be 100 mg per deciliter. In +3 there will be 300 mg per deciliter. In +4 there will be 1 gram per deciliter of urine protein will be there. There are different methods of estimation of proteinuria will be there. In case of heat coagulation test, we will add acetic acid and we collect the urine sample and the topmost layer. If there is any coagulant is formed, then
Just tell me the names.
Heat coagulation with acetic acid and then the dipstick method will be used. It's a cheap and in assess a less time consuming. And next we can assess the protein creatinine ratio. We can whether the creatinine is elevated or not. Normal limits is within 0.3 millimoles per deciliter. If it is more than 0.3 millimoles, then the protein creatinine ratio is also elevated in the urine.
Okay. So the blood and the urine examination is over, no?
Yes.
Now tell me, Lata, tell me about the ultrasound. Importance of ultrasound in preeclampsia. Okay.
And if there is persistence of diastolic knots in uterine artery greater than 20 weeks, it is indicator of preeclampsia. In case of in ultrasound, so usually in third trimester they'll be looking for the fetal parameters to rule out any IUGR, fetal growth restriction.
Yeah.
we have to look for the liver status to rule out the oligohydramnios. We also have to look for the placental maturity, any calcifications or influx are present or not. So coming to the third trimester, in Doppler we'll be looking for the umbilical artery and MCA. In umbilical artery we have to look for any decreased diastolic flow or reversal or absent diastolic flow. In MCA artery we have to look for the pulsatility index. If it is less than 1.2, that is significant.
Okay. So coming to the discussion. So Lata, now tell me, how do you classify the hypertensive disorders in pregnancy?
We can classify as gestational hypertension, preeclampsia without severe features, preeclampsia with severe features, eclampsia, chronic hypertension and superimposed preeclampsia, chronic hypertension.
Now tell me, what is gestational hypertension?
Gestational hypertension is defined as a BP recording of greater than 140-90 millimeters mercury, which is recorded on 2 occasions 4 hours apart after 20 weeks of gestation, and there won't be any associated proteinuria in this case, and it will be subsided after before 12 weeks postpartum.
What is preeclampsia?
So preeclampsia is in this case there will be BP recording greater than 140-90 millimeters mercury with associated proteinuria, or there may be endoorgan damage or a thrombocytopenia in this case, madam.
Is there any chance of eclampsia in gestational hypertension?
Yes, ma'am.
What's the percentage?
10%, ma'am.
Very good. Okay, then what is delta hypertension?
In delta hypertension, the BP recordings will be normal with features of preeclampsia, and here the mean arterial pressure will be greater than 105 millimeters.
How do you calculate mean arterial pressure?
Mean arterial pressure is diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is the difference between the systolic and diastolic blood pressure.
What is white coat hypertension?
So here the BP recordings will be more whenever the patient is in the presence of the healthcare professional.
What is masked hypertension?
In masked hypertension, the BP recording will be less than 140-90 millimeters mercury in the clinic, whereas the BP recording will be greater than 135-85 millimeters mercury when the patient is out of the clinic.
What is the rule of 30-50?
In previous days, whenever there is rise in systolic blood pressure by 30 millimeters mercury or diastolic blood pressure by 15 millimeters mercury, so they consider this as hypertension. Nowadays, this rule has no use now.
Oh yeah, tell me, what is the etiopathogenesis of preeclampsia?
Coming to the etiology of preeclampsia, first the exposure of chorionic villi for the first time and abundant exposure of chorionic villi for the first time in conditions such as molar pregnancy and multiple pregnancy, and the genetic predisposition and immunological conditions, expression of HLA-8, and then chromosome responsible for preeclampsia is located in chromosome 13. If
Kachima. Maulia, tell me about the etiopathogenesis of preeclampsia.
etiology of preeclampsia, exposure of chorionic villi for the first time, exposure of chorionic villi in abundant amount in conditions such as molar pregnancy and multiple pregnancy, genetic predisposition and immunological conditions. In immunological conditions, the expression of HLA gene and
Okay, Maulia, tell me the etiopathogenesis of preeclampsia.
etiology of preeclampsia, exposure of chorionic villi for the first time and exposure of chorionic villi in abundant amount in conditions such as molar pregnancy and multiple pregnancy, genetic predisposition, immunological conditions, and when coming to the pathogenesis, there is impaired second phase of trophoblastic invasions into maternal spiral arteries at the level of myometrium, which in turn results in placental hypoxia.
So that is the phase belongs to the placental syndrome.
You continue. Placental syndrome, which in turn results in release of free radical species and cytokines and interleukins are released, which in turn results in oxidative stress and dynamics. These all contribute to the placental syndrome. The gene responsible for preeclampsia is located in chromosome 13. In case of trisomy 13, there will be increased incidence of preeclampsia by about 30 to 40%.
Yes.
The expression of HLA gene will be there,
Yes.
and T helper cell bias will be there. In general, pregnancy.
So that is type 2 bias.
Type 2 bias will be there. In general, in pregnancy, type 2 helper cell 2 will be elevated. In case of preeclampsia, T helper cell 1 is more when compared to T helper cell 2.
So T helper cell 1 cells, T helper 1 levels are elevated when compared to the T helper 2. Okay. So now coming to the maternal syndrome.
There is a disparity between angiogenic factors and anti-angiogenic
Yes.
factor will be there. Vasopressors are elevated because of this oxidative stress.
So vasopressors like
angiotensin 2, endocrine will be elevated, and then vasodilators such as prostacyclin levels will be decreased, and
nitric oxide is
Nitric oxide
decreased,
decreased and
thromboxane is increased.
and
These all lead to
soluble
the
FMS
vasospasm.
Yes.
Yes.
These all contribute to the vasospasm.
So nowadays we are making the trials for estimation of the serum endoglin as a predictor for preeclampsia. Okay, if the serum endoglin is elevated, there is a chance of 30 to 45% elevation of the preeclampsia, incidence of preeclampsia.
And if there is persistence of diastolic notch in due to an artery greater than 20 weeks, it is indicator of preeclampsia. In case of in ultrasound, so usually in third trimester we'll be looking for the fetal parameters to rule out any IUGR, fetal growth restriction. We have to look for the LIGO status to rule out the oligohydramnios. We also have to look for the placental maturity, any calcifications or influx are present or not. So coming to the third trimester, in Doppler we'll be looking for the umbilical artery and MCA. In umbilical artery we have to look for any decreased diastolic flow or reversal or absent diastolic flow. In MCA artery we have to look for the pulsatility index. If it is less than 1.2, that is significant.
Okay. So Lata, now tell me, how do you classify the hypertensive disorders in pregnancy?
We can classify as gestational hypertension, preeclampsia without severe features, preeclampsia with severe features, eclampsia, chronic hypertension and superimposed preeclampsia, chronic hypertension.
Now tell me, what is gestational hypertension?
Gestational hypertension is defined as a BP recording of greater than 140-90 millimeters mercury, which is recorded on 2 occasions 4 hours apart after 20 weeks of gestation, and there won't be any associated proteinuria in this case, and it will be subsided after before 12 weeks postpartum.
What is preeclampsia?
So preeclampsia is in this case there will be BP recording greater than 140-90 millimeters mercury with associated proteinuria, or there may be endoorgan damage or a thrombocytopenia in this case, ma'am.
Is there any chance of eclampsia in gestational hypertension?
Yes, ma'am.
What's the percentage?
10%.
Very good. Okay, then what is delta hypertension?
In delta hypertension, the BP recordings will be normal with features of preeclampsia, and here the mean arterial pressure will be greater than 105 millimeters.
How do you calculate mean arterial pressure?
Mean arterial pressure is diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is the difference between the systolic and diastolic blood pressure.
What is white coat hypertension?
So here the BP recordings will be more whenever the patient is in the presence of the healthcare professional.
What is masked hypertension?
In masked hypertension, the BP recording will be less than 140-90 millimeters mercury in the clinic, whereas the BP recording will be greater than 135-85 millimeters mercury when the patient is out of the clinic.
What is the rule of 30-50?
In previous days, whenever there is rise in systolic blood pressure by 30 millimeters mercury or diastolic blood pressure by 15 millimeters mercury, so they consider this as hypertension. Nowadays, this rule has no risk factors. So there may be history of a chronic hypertension or pre-gestational diabetes mellitus or assisted reproductive technologies and chronic renal diseases, autoimmune diseases, thrombophobia, and already all come under high risk factors.
You tell me about what are the other methods to assess the fetal well-being.
Based on period of viability, we will assess the fetal well-being. According to our developing country standards, after period of viability is around 28 weeks. After that, we assess the fetal well-being. First, we will go with the whether fetal movement count is normal or not. We ask the mother to count the fetal movement count. At least there will be 10 movements after within 10 half an hour interval. Cardiac count of 10 will be there. Then we go for NST now. Whether fetal cardiac activity is there good or not, and B2B variability is present or not. It will be assessed after 32 weeks of gestation age now.
So when do you call the NST as reactive?
If baseline cardiac activity is 110 to 160 beats per minute and B2B variability is present of about 5 to 25 beats and more than 2 accelerations of about 15 beats lasting for about 15 seconds and no decelerations is present, then it is known as reactive NST. And we will also assess the biophysical profile and modified biophysical profile. In modified biophysical profile, there is only NST and AFI component. If AFI and NST are normal, then the fetus is not in compromise.
What are the components of biophysical profile score?
NST, AFA, along with that we will do ultrasonography, motion ultrasonography for about 30 minutes now. We will assess the fetal breathing activity, fetal body tone and body movements now. Breathing activity of one activity and movements of about 3 movements in 30 minutes in total and single flexion and extension in 30 minutes. If these are present, then it is.
Lata, tell me the complications of preeclampsia.
We can divide into maternal and fetal complications. Let me discuss the maternal complication. We can divide that into antepartum, intrapartum, and postpartum. In antepartum, starting with the CNS, there will be cerebral edema, hemorrhage, and convulsions. Coming to the ocular system, there might be macular edema, vitreous hemorrhage. There may be blooding of visual retinal detachment. Then in case of RS, there may be pulmonary edema, pulmonary embolism.
Yes.
Coming to the hepatic system.
What
so
about
there-
cardiac?
In cardiac, there will be left ventricular failure. Ma'am.
Yeah, left ventricular failure is more common.
Yes. In case of hepatic system, there might be HELLP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. And there also be right hypochondrial pain because of the stretching of the presence capsule due to the subcapsular hemorrhage or the other hepatocellular necrosis. As well. In case of renal, there may be endotheliosis, which causes proteinuria, and there may be acute kidney injury, proteinuria, oliguria. In case of this is in case of antepartum. Coming to
What
the
about blood?
in blood, there might be
Hematological complications.
hematological complications. There might be hemolysis in case of HELLP syndrome, thrombocytopenia in case of HELLP syndrome. And
What is the reason for thrombocytopenia?
so in the preeclampsia, there may be endothelial damage which leads to the platelet activation, aggregation, and there may be microangiopathic hemolysis. And all this leads to thrombocytopenia. So coming to the intrapartum complications, because of the incoordinated uterine action, there may be increased chances of the operative vaginal deliveries, or we may land up in patient will land up in cesarean section.
Yes.
So or there may be a risk of postpartum hemorrhage. In the postpartum period, there is risk of
And also there is a risk of eclampsia in intrapartum also, no?
eclampsia there is risk of eclampsia in all the stages, I mean antepartum, and postpartum conditions. In postpartum, there is a risk of subinvaluation, such as lactation failure.
What about postpartum eclampsia? What about press?
Yes, ma'am. In postpartum, there may be a risk of postpartum eclampsia and press.
What is press?
Posterior reversible encephalopathy syndrome.
Yes, what is the management of press? What is press, Lata?
No, it is posterior reversible encephalopathy syndrome.
How do you manage this case?
It resolves on its own, madam. Whenever there is cerebral edema, we can give mannitol, madam.
So as per the advice of the neurologist, we will go for mannitol and anticonvulsants are started. Okay. Okay, now Maulya, tell me the fetal complications.
Most commonly because of placental insufficiency, there will be FGR now. The risk of prematurity will be there because of chronic hypoxia.
So most of the times the prematurity is
because
induced, no?
yes, nitrogen prematurity will be there, and sometimes because of hypoxia also premature activation of carbohydrate will be there, and there will be increased incidence of NICU admissions because of during labor will be instrumental deliveries. There also there will be increased incidence of fetal injuries will be there. Cerebral hemorrhages will be there because of premature babies, and then post delivery increased incidence of NICU and SNCU admissions because of prematurity, and all these injuries due to instrumental deliveries will be there.
Okay, good. Finish the pregnancy, or you want to terminate the pregnancy in your case?
No, madam, I want to terminate the pregnancy, as it is a simple preeclampsia case with 30 weeks serious gestation age. So in this case, after assessing the patient score, if it is less than 6.
Why you don't want to give any steroids, as it is only 35 weeks, no?
Yes, ma'am. After completion of the steroids, I'll be.
What steroids you want to give?
Dexamethasone or metamethasone. If it is dexamethasone, I'll be giving 6 mg in pathophysiology 4 doses, 12 hourly 4 doses. In case of metamethasone, 12 mg 2 doses 24 hourly.
Okay. Then?
After completion of the steroids, I'll be assessing the patient score of this patient. If the score is less than 6, then I'll increase the patient with body selection. In case of first stage of labor, I'll be monitoring the patient monitoring the progress of the labor, and I'll be assessing the fetal heartbeat every 15 minutes. When coming to the second stage, I'll be cutting down the second stage of labor.
So you cut short the second stage with the outlet?
Second stage of labor using vacuum or
Outlet process, yes. Then how do you manage in the third stage?
In the third stage, I'll be performing active management of third stage of labor. And I'll be using oxytocin, and I should avoid methotrexate.
Yes, good.
So for the prevention of BPH.
Maulya, what contraception you want to advise to the patient? As the baby is a preterm baby, no? You can't advise the tibectomy to this patient.
since it is a case of hypertensive disorder, we'll go with the intrauterine contraceptive device or progesterone only pills now. Combined oral contraceptive pills are usually avoided because of there is a high risk of cardiovascular and thrombotic risk will be high and hepatic injury will be high in case of combined oral contraceptive pills. In this case, I preferably suggest intrauterine contraceptive device.
So it isn't it
Predators of preeclampsia increased fetal self-returning in the early pregnancy, and there will be also increased soluble FMS like tyrosine kinase, endonin, leptin, uric acid, homocysteine, and triglyceride levels, and also pregnancy-associated plasma protein. There will be persistence of diastolic notch in the uterine artery beyond 20 weeks of gestation, and rollover test. So we will check the BP of the patient in the left lateral position, and we will ask the patient to lie in the supine position. Again, we will be checking the BP. If there is increase in diastolic pressure greater than 20 millimeters mercury, then it is predictor of preeclampsia. And the last one is mean arterial pressure. If the mean arterial pressure is greater than 90, then it is a predictor of preeclampsia.
Can you prevent preeclampsia?
Yes, madam, we can prevent preeclampsia by we can suggest the patient to have a high protein diet, and calcium supplementation also helps. In some cases,
What is the dose of calcium? Lata, is the preeclampsia preventable?
No, it is not preventable, but we can reduce the risk now. Because we have to identify the risk factors, and we can give a calcium supplementation of 2 grams per day, and we can also advise low dose aspirin 75 milligram per day. We can start it soon after the confirmation of the pregnancy, and we can give it up to 36 weeks of pregnancy. In case of APLA or thrombophilias, we can suggest a heparin also.
What is class trial?
So this low dose aspirin, collaborated low dose aspirin study in pregnancy. Here we can give aspirin at a dose of 60 mg per day. So this has showed a decrease in preeclampsia.
Yeah, only we can take the measures to prevent the preeclampsia, but it's not 100% preventable. Okay. So now, Maulya, tell me about the antihypertensive therapy. What antihypertensives you know?
First time oral antihypertensive is levodopa. Its mechanism of action is both combined alpha and beta blocker. It can be given at the interval of 24th hour or 12th hour or 8th hour. Maximum per single day, it's a dose of maximum for 2400 mg can be given.
What are the side effects?
Hypotension will be there. Maternal flushing will be there.
Yeah. What about the nifedipine?
Nifedipine is a calcium channel blocker. It can be given at a dose of 10 mg or 20 mg can be given. It is maximum given at 120 mg per day.
What is the half-life? 8 hours.
8 hours is the half-life of nifedipine. Next, its side effects are reflex maternal tachycardia will be there. Along that flushing and hypotension.
Headache is a common complaint with the nifedipine. Yes.
In case.
What about the methyl-dopa? Are you using methyl-dopa?
Some incidence of postpartum depression because its mechanism of action it is acting as a centrally acting dopamine antagonist.
Nowadays we are not using the methyl-dopa. Okay, what is the treatment for hypertensive crisis?
We can go with IV levodopa. First initially 20 mg can be given. After that within 10 minutes we assess the BP. If BP is not under control and still is high, we can increase double the doses. Then next 40 mg can be given. Up till 80 mg can increase. Maximum dose of 220 mg can be given.
Yes, what are the side effects?
Hypertension will be
Yeah. So that's about the antihypertensive for hypertensive crisis.
Hypertensive can be used along with that is only nitroprusside can also be used in case of hypertensive crisis.
Yes. What Lata? You tell me something about eclampsia. What are the regimens you want to give for eclampsia?
Conversions occurring in the patient of preeclampsia, we will say as eclampsia. The common regimen what we are using is Fetal regimen. So it contains a total dose of 14 grams.
So first you have to stabilize the patient.
Yes, ma'am.
Then you have to go for the regimens. So the commonly used drug is the magnesium sulfate.
Yes.
And the regimen commonly followed in our hospital is the Pritchard's regimen. Yes. Now tell me about the Pritchard's regimen.
Fetal regimen, a total of 14 grams is given. So in that 4 grams is given as IV and 10 grams is given as IV. So IV dose 4 grams of 20% magnesium sulfate, which is given as low IV over a period of 15 to 20 minutes. In iron regimen, 5 grams of 50% magnesium sulfate is given as, and the 5 grams is given in each buttocks. Yes, ma'am. After that, this is loading dose. After that, maintenance dose is repeated every 4 hours. So which has to be repeated, which has to be continued for 24 hours from the last episode, whichever is the last episode. For example, whether the seizure or the delivery, whichever is the last episode, and from there we have to continue for
So what are the parameters you want to monitor?
We have to
You
look
want to
for
give the
the
maintenance dose.
we have to look for the deepener reflexes, respiratory rate and urine output, madam. If any decrease in the urine output or the renal reflex is lost, then we have to suspect for magnesium
What are the
sulfate.
therapeutic levels of magnesium sulfate?
Less than 7 milliliters, ma'am. If it is 7 to 9, and the initially reflexes will be lost, ma'am. Thereafter, respiratory depression will be there, ma'am. And if it is more than 20, then will be cardiac arrest will be there.
What is the mechanism of action of magnesium sulfate?
It blocks the NMDA receptors, madam.
Yes.
That's why. So that conditions won't happen.
And it also reduces cerebral edema. Okay. What are the other regimens you know for eclampsia?
Suspend regimen.
What is that?
One
What
time
is
of
this?
The other regimens of MgSO4 are intravenous regimens such as Juiceman's regimen. In this IV, MgSO4 is given at 4 grams IV loading dose followed by 1 gram per hour infusion for about 24 hours. And other regimens are Silvai regimen. In this there will be 6 grams of IV infusion followed by 1 gram per hour of IV infusion for about 24 hours. And then 4 grams of IV infusion is given. And then 3 grams in each buttock loading dose is given. And then 4 hours at 4 hour interval 2.5 grams of IM MgSO4 is given.
Okay, the patient is having status epilepticus. Status epilepticus, what is the management?
then we can do thyroid controls also.
And also you have to terminate the pregnancy.
Thank you for giving us this opportunity.
Thank you, ma'am, for giving us this session and this case presentation.
Yes, thank you Lata and Maulya for your nice presentation. And I hope all the postgraduates utilize this video.